Hi, everybody. Can you hear me?
Yes.
Yay. So I think we're just going to get started, and if people come, then they come. So since we're talking about mental health, we thought we would open with 2 grounding activities. So the first one is called a box breathing. So it helps us sort of, and you can do this anywhere that you are, and it helps us just sort of calm down. And so why don't we start now? You just have to follow my voice, and it's going to help you just breathe and slow down your breathing, okay? So you're going to breathe in for a count of 4, and we're only going to do 5 deep breaths for this. So you're going to breathe in for a count of 4, hold for a count of 4, breathe out for a count of 4, and hold for a count of 4. So breathe in, hold, breathe out, hold, 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 breathe in, and you can go back to breathing. How did that feel for everybody? Hopefully it helped you calm down a little bit. The next grounding activity that we're going to do is called a 5, 4, 3, 2, 1 activity. So you're going to acknowledge 5 things in the room that you can see, right? Or if you're in your car, 5 things that you can see in your car, 4 things that you can touch around you. So sometimes I touch my own hair just because it's like a texture thing if you can't find 4 things around you that you can touch. 3 things that you can hear, even if it's the air conditioning or the buzzing of like white noise. 2 things that you can smell, hopefully pizza. And 1 thing that you can taste, right? And so that grounds you to the here and now. So if you're starting to get anxious or you're starting to feel a little bit overwhelmed or something, it helps you calm down and be grounded to the here and now. Anyway, so I'm Christine Peters. So I'm a therapist, and this is just really important to me. So I want to put together something for the community to be able to get some answers from different panelists who are experts in their field. And so one of the experts that is going to be running this whole thing is Joe Pinion, who's a Yonkers native. He grew up here, good old hometown boy, right? He's the former director for youth development at MHHC Foundation, which is the philanthropic arm of the Morris Heights Health Center. He's currently a political analyst on CNN, Fox News, and CBS News, and a senior fellow for Deploy US, a national nonprofit dedicated to foster bipartisan renewable energy solutions. So without further ado, Joe.
Well, it is good to be here with my fellow Yonkersites. I always joke it's if it's not on the calendar, there's a good chance I'm not going to make it back to Yonkers before 11 p.m. because Lord knows the days get longer by the day. But thank you for joining us. We're here to have a robust, informative conversation about mental health, the state of affairs here in New York, what we can do as citizens in Yonkers to help address the mental health deficiencies of our communities, of our neighbors, of our loved ones. And so just wanted to give a chance for the people who have joined us here to speak on this, to give themselves a brief introduction. We have Michael Orth, he's the Commissioner of Westchester County Department of Community Mental Health. We also have Dr. Drew Mulane, he's the Director of Innovation for WJCS, and also Integration and Community Partnerships. We have Audrey McInerney. She's the president of NAMI, that's the National Alliance of Mental Health Illnesses in Westchester. Also, Jason Duncan, PhD, he's the owner of the Cognitive Behavior Therapies and Assessment Association. I guess he is the host of the Saturday podcast. And last but not least, Suzanne Schwartzberg, who's again, talking from her personal experience about conquering the undertow, learning to breathe. Again, that is her pen name. I'll start with Michael, and then we can go from there.
Good evening, everyone. Well, I'll try to speak very loud. Can everyone hear me okay? Thank you. First of all, thank you for being here and making mental health and mental wellness a priority. So I really look forward to a conversation with you guys, and hopefully there's something that everyone can get out of this discussion. And also, May is Mental Health Awareness Month. So even though it's June 1st, we spent a lot of time in May talking about mental health and wellness because we all have mental health, right? And that's what we're here to talk about today. As Joseph mentioned, my name is Michael Orth, and I have the privilege of serving as Commissioner of Westchester County Department of Community Mental Health. We're actually a branch of county government, thank you, that has responsibility for the mental health, substance misuse, and developmental disabilities system. So we're in charge of organizing, making sure we have services on prevention, early intervention, treatment, and recovery, and we work closely with private practitioners, with agencies, with schools. I just left a meeting with the police departments in Westchester County. So our goal is to embed mental health, mental wellness for our entire community, but also for those who may be challenged, which most people are during their lifetime with a mental health issue, to make sure they get the help that they need. So it's a pleasure to be here.
Hi, everybody. I'm Audrey McInerney. I'm the president of NAMI Westchester. NAMI stands for the National Alliance on Mental Illness. We are an affiliate of a national organization that is dedicated to helping, supporting, educating, and advocating for people with mental health conditions and their families. Our Westchester chapter has many programs that I'd like to talk about or let you know about later during the course of this meeting. But we do a lot of work to support people and educate them and advocate for them in the legislature.
Thank you and good evening. I'm William Mullane with Westchester Jewish Community Services, and I'm happy to be here representing community behavioral health providers like WJCS, but Yonkers actually has a number of different community behavioral health providers, WJCS, MHA, Andrus, FSW, all of whom are serving the Yonkers community. And so I'm excited to talk about the services that organizations like WJCS and other community behavioral health providers offer the community. So looking forward to that.
I think this works. Okay. I'm Jason Duncan. I own a private practice, one office here in Westchester, Greenwich, Connecticut, and in the city. But more importantly is my work that I try and do in dissemination and trying to educate people on empirically supported treatments. Not all mental health treatments have research and validation behind it, and I feel like if we are trying to get more therapy out there, it should be therapy that works. So they mentioned the podcast that I do, which is completely free, which is for the community to learn about empirically supported treatments. I'm part of the National Empirically Supported Treatment Organization, one of them, working towards dissemination and trying to get sponsorship and funding to train people and to also disseminate information in the local empirically supported treatment in the tri-state area, again, hosting trainings for people at pretty reasonable rates to try and get that information out there.
Last but not least, as they say. Raise your hand if you or someone that you've known in your life has struggled with their mental health. Wow, isn't that amazing? Every single one of us has been touched by this important topic, and that's why I'm so grateful that this has been brought for us to discuss together tonight. Although I know we've come a long way the past 15, 20 years talking about mental health, obviously we're not there yet. There's still a lot of people that are dealing with things and often are overwhelmed at this point about the amount of options of where do I go, who do I talk to, how do I start, how can I afford this? And that's a lot what we're gonna be speaking about today. But I wanted to take a moment. I know I don't have all the credentials that some of these lovely people do, but I wanted to share a little bit about myself and my journey. I was brought up in a world where if you stayed positive, if you just kept going, then everything would work out. And that worked for me for many years. That was my coping. Whatever it was, look at the positive, look at the bright side of things, and you have a fight with a friend, well, you make up, everything's okay. You fail a test, well, you learn from it. And that kept me going for a really long time. I graduated with honors, I lived in different cities, until a few years where I had a lot of big things happen to me in my life that none of us are really prepared of how to deal with. And I decided, I know what I need to do. I just need to keep on going and everything will be okay. And what I realized the biggest challenge to me was mental health, is it's not like physical health where you get food poisoning in 24 hours, you know exactly what's going on, there's millions of experts out there on it. It's not like the flu that it's just, okay, I go to bed one day, I wake up, oh, my stomach hurts. Mental health is different in the way that it doesn't happen overnight. It's not something that you wake up one day and you're like, oh my gosh, I must be depressed. Oh my gosh, I'm feeling really anxious. It happens over time. And for many people, you have a really close connection with who you are as a person, and then you don't realize that the years have gone by and you're not thriving anymore. All you're doing is just getting up each day, surviving, and hoping to go to bed at night. Recently, I visited my niece in college, and she told me that some days she just can't wait to get through the day so she can go to bed. And that just broke my heart, because I imagine how many young people are out there with the years that we all look back and say, oh, I wish I was in my 20s again. I wish I was a teenager again. I need to be free and not have work and not have a family. They're just trying to get through the day. And so many people still have that mentality. Instead of loving and living their life, they're just trying to see what they can do to survive. And I know that because for a long time, I started to think that things of just breaking down, crying in my car was just me being emotional, because that's what I've been told, growing up. And as the days went on, I forgot who I really was, and I started thinking that this new person was me. It never came across to me of oh, maybe I'm dealing something, maybe I have a challenge. I went to the doctor even, and he said to me, oh, you're just a little stressed, you'll be fine, because my stomach kept hurting every single time I left work. As time went on, I knew something was wrong, and friends would tell me, oh, you should seek help, you should seek help. But when you're feeling that way, it's really hard to get the energy and the courage to go to a scary place and speak to somebody. And that's why I'm a big believer in the idea of community help. This concept of self-help and self-help books, it works to an extent. Yes, you need to help yourself as an individual, but we also need to look out for each other as a community. It can't be oh, well, you have this problem, go get therapy. Sometimes you have to be the one that says to your friend, let me sit down with you on the internet and let me try to help you find a therapist. And I know that because people in my life have done that for me. Eventually, when I lost my job, and I was about half across the world in Bali, actually, where people think would be a dream, and my friends told me I needed to come home because they knew how much I was struggling. And I came home and I was hospitalized for suicide ideation. Through that and years of therapy and really choosing myself and personal development, I'm able to be on this side of the room today. And that's why I think there's so many people out there that aren't telling this story that have those similar kind of experiences. And that's why taking the time out of your lives, whatever this day today is, you may think it's just something hey, I'll stop by or whatever it is, but it means a lot. Like I told Christine, even if 2 people show up today, you don't know who you're going to be impacting, that you're going to bring this back to people in your life, and they're going to bring people back to their lives. So definitely participate, pay attention today, and I hope we all walk away with something powerful.
Well, thank you so much for that personal testimony. Michael, I want to start with you. Again, kind of leaping off from that point and talking about the challenges as it relates to government services. One from an individual standpoint, but also from a family standpoint. We know that we've been through COVID, which certainly put a strain on the mental health of people of all walks of life. And so just talk to us a little bit about, number one, obviously the funding deficit that has existed for far too long as it relates to mental health, but also then the challenges of just getting people to know about the services that are available through the government.
Yeah, well, thank you. It's a good question, and we all have our own experiences, perhaps in the audience, about challenges accessing care or success stories. So that's always the most important, our personal stories. But one of the things that's interesting to note, when we think about mental health, it's a public health issue, right? Like car fatalities, health issues, cancer. And while in this country, all major health issues. The rates of fatalities have gone down from breast cancer to car fatalities, the other forms of cancer. The rates of overdose, fatal overdoses, completed suicides continue to go up. So we have to wonder what are some of the issues, as Joseph mentioned. And one of them is obviously stigma. The fact that we're in a room talking about mental health and sharing is a real positive step, because you go into a lot of rooms and as Suzanne shared, people don't really talk about mental health issues. So there's definitely the stigma issue. There's also something called healthcare insurance parity. And this was really notable during the pandemic, where most people don't even check their insurance plan and their behavioral health plan until they actually need it. And there's federal parity regulations that requires insurance companies or Medicaid managed care to pay a therapist, to pay for evidence-based treatments. Unfortunately, they're much lower. It's not in parity with the federal government. So I'm sure many of us, myself included, have tried to access mental health services. There's a waiting list. There's a copay that's significant. So even when we take that big leap to try to get help, it ain't always there for a lot of reasons. And that's obviously a big issue. And then the workforce challenges. This isn't a field where people are dying to become licensed social workers or psychiatry. So we want to build the workforce. I think the tipping point with the pandemic, it did sort of normalize it, that we feel anxious, we feel isolated, we feel depressed, we may have an extra glass of wine or two to help us cope during the pandemic. So there's definitely more of a recognition that we need help. And add to the fact that many of us lost a loved one, so there's grief. Many of us had food insecurities, housing issues, employment, and that all leads to our mental health and our ability to cope. So clearly there's a need for more services. The governor of New York recently passed the budget, and it was the largest by far budget in mental health. It was a commitment of $1 billion going to mental health in New York State. But how does that trickle down to support schools, first responders, the agencies that are doing the work? That's still a question. So we still have a long way to go, as someone mentioned here, and advocacy and who we elect in office and where do we make it as a priority in our city, in our county, in our state, and in our national government. Mental health has to be a priority.
Absolutely. Audrey, I want to come to you because I would love to hear what kinds of trends you're seeing as you interact with those people seeking help. What are you seeing right now that gives you hope? What are the things that give you pause? And what are the things that you think people can do in their own personal capacity to help address those trends?
Thank you. Well, as Michael mentioned, the COVID pandemic caused people to pay more attention to mental health issues. Unfortunately, the COVID pandemic had a significant negative impact on people's mental health, and in fact 20% of both young people and adults say that they've had a significant negative impact as a result of the COVID pandemic. And people already with mental health diagnoses, about 50% of them say that their mental health was deteriorated during the pandemic. So it's a serious issue that NAMI continues to address. We are there for people who do have mental health concerns. One of the issues in mental health that was, of course, exacerbated by COVID is isolation. It's isolation from stigma, as Michael mentioned, and isolation from just thinking, as I did at one time, I'm the only person in Westchester County facing these issues. But NAMI is here to, one of our taglines, which is very important, is, you are not alone. And we are here to help support people with mental health conditions and their families. We have several support groups for both of these groups. We have classes for family members and for people with mental health diagnoses that help explain what mental health what mental illness is, that it's a brain disorder, it's not a character flaw, it's not something that somebody did, nobody's fault. We educate people about coping skills, empathy, problem solving, and that kind of thing. And we have several other programs as well that are designed to help people get through this crisis in mental health. And as Michael mentioned, it's very hard to find mental health providers that have the time to work with individuals who are reaching out to them. I will tell you, you can call NAMI Westchester. Here's the number, 914-592-5458, and they will help you identify and get access to resources. So thank you.
Absolutely. Jason, I want to come to you, and then Dr. Drew, I'll come back to you. You know, I think, you know, one of the things that we talk about here, you hear the Surgeon General talking about the epidemic of loneliness. You hear about people now trying to, on a trial basis, see if AI can be the cure for loneliness. I think on some basic level, what we don't talk about enough is that there's no type of a synthetic replacement for human interaction. And so tell us a little bit about, you know, obviously in your practice, what you're experiencing. Are there certain types of conditions? Obviously there's no silver bullet or, you know, one type of kind of presentation of mental illness, but are there any kind of commonalities that you see, themes that you see that people might be able to recognize in their own day-to-day life?
Just to piggyback on a comment that you said about loneliness being up, I think that's a critical issue. Like, adult loneliness is higher than it's been. And our community really isn't built to make friends as an adult. And I have so many clients coming in saying, I want to make friends, I don't know where to make them. And I say, if you figure it out, let me know, because I'll do it. I'll do it too. There was a Harvard study, longest research study, and they looked at everything: blood markers, money, cars, power. Started in, like, I think 1950 or maybe earlier. And what they found at the end of it was your relationship with your long-term romantic partner and with your friends predicted how long you were going to live, how healthy you were going to live, and how happy you were. So it wasn't just your mental health, but your physical health. And at the age 50, when they looked at those markers, they could predict that at 80. So community is incredibly important. And even though I'm a therapist and people come in for anxiety and depression, I almost want to advocate, even though it's against my best interest as a business, to make me less needed, right? Because by the time that you come to a therapist, the problem is already there, and now we're trying to remove the problem, right? Rather than having more early intervention and more community, not community-based intervention, but building community so people have support. It doesn't have to be therapy. 50% of people get their anxiety or depressive disorder by the time they're 14. Think about that, 14. When I was in elementary school, they had me singing like self-esteem songs. In PS29, we were way all over school. But nobody was talking to me about emotion regulation, facing my fears, self-concept, how I was talking to myself. And I think it's really important that there's a conversation on how do we get this in earlier to prevent a primary intervention rather than what I do, which is tertiary, third wave. The problem is already here. So I just wanted to plug that in. And some other facts: adult loneliness on the rise, teen mental health keeps getting worse every decade, and the misery index gets worse every decade. And so society is trending into a less healthy, less happy place. And so that goes outside of just therapy, that goes into community, how we're living our lives and trying to have healthier patterns as human beings and supporting each other. As for typical presentations that we treat, it's mostly anxiety, depression, social anxiety, generalized anxiety, OCD, and all of it is up. There's nothing specifically that is higher than others. During COVID, there was more family therapy coming in, just because people were stuck together in the house for longer periods of time. And, you know, family is our greatest resource and our biggest frustration, right? I think we could all feel that, so that was an issue there too. I'm not sure, I kind of derailed off, but was there something that I should?
No, that was good. I think that actually brings me to what I want to talk to Dr. Drew about, because I think, honestly, you know, we don't want to be all doom and gloom, right? We recognize the challenges of government. We see the presentations in the private sector. We see some of the trends that are developing here. where, from your work with WJCS, as we try to find, the fillers, so to speak, the cracks in the foundation, the integration with community, where does that community integration come in? What are some of the things you guys are working on to try to fill the gap, as we recognize that $1 billion is not sufficient to deal with all the mental health issues, as we recognize that there aren't nearly enough social workers or PhDs to go out there to give people the access they need, or the resources in the families to be able to pay for them?
Yes, that's a big question, but I'll do my best. So one of the things that community behavioral health providers like WJCS do is that we actively partner with faith-based institutions, churches, synagogues, temples, what have you. Also, the local municipalities, so like the city of Yonkers, we often partner with DCMH, the Department of Community Mental Health at the county level. So there's a lot of partnering with various entities to make sure that our services are infiltrating those communities, right? We all know that it's hard to get access to treatment for youth, right? Youth is actually one of the categories of individuals that have the hardest time accessing care. And that's because those after-school hours are so limited and the demand is pretty significant. And so, like Michael Orth said, pushing community health providers into school-based settings where they can help people to function optimally, build peer relationships, succeed academically, remain engaged in school is important. Likewise, also connecting with people's faith institutions is a really important piece. So it's not just about providing treatment in those systems, but it's also helping those systems to help people to enter care sooner. I think we've all said that oftentimes there's a pretty significant delay. I think the data says it's about 10 years on average before someone enters treatment. But those 10 years generally represent a slow unwinding of their baseline functioning. So it's a successive kind of decline in functioning. And if we were able to intervene earlier in our friends' lives and our families' lives to get them connected to care, that would be wonderful. So one of the things that we do in partnership with the county is we offer mental health first aid training so that people can learn how to support the people in their lives who have mental health concerns. That's a training that's offered for youth, people who work with youth, or parents. It's offered for people who work with adults, first responders, veterans. NAMI has a ton of wonderful programs, In Your Own Voice and other programs. So a lot of community-based organizations are trying to infiltrate different community supports to make sure that we can help people to enter treatment earlier. Then the other thing, something that's not paid for by insurance, is peer-based services. So having people with lived experience be able to help people to enter and remain engaged in care, but also determines or help to address some of the social determinants, right? Like Michael said, food insecurity, housing insecurity, other factors, lack of engagement in physical health care, to actually support whole person recovery.
Absolutely. Suzanne, I want to come to you because obviously we have a captive audience here, but certainly I don't know if it's a fully representative audience, as we know that there are so many people whose lives, as you mentioned, are touched by mental health issues. What can be done from your perspective? What should be done? And what should the audience be thinking about as it relates to getting people to recognize some of the warning signs that Dr. Drew was just talking about that lead them into seeking care earlier in that 10-year delay process?
That's a great question. Thank you. No, that's a great question. One thing that I really like that was mentioned before is I love that idea of the first aid, of people educating themselves of what can I do. Because I've had people come to me and they're like, I don't know what to say or do to this person. I don't want to make them worse. And once they find out the kind of conversations that they can have with people, even, you don't have to be totally trained. You have to go to school in order to be able to have a conversation with somebody that can absolutely, change their lives. And, but that takes the education of taking that on and saying, I want to know that if this does happen in my life, how I can handle this kind of conversation. And that was one of the reasons actually why, I wrote the book, because I think a lot of people don't understand still. They're like, I don't understand, why is this person, I invited them out, why won't they come out? And it's hard when you're not in that mindset to understand what's going on in that person's brain when you're coming from a more stable mindset. So asking people more about their experience. And one of my favorite things actually is something that was done in Australia, and instead of saying to people, how are you? And asking that question, because people are going to say, oh, I'm good, I'm fine, even if their life's falling apart, even if your house is on fire. You're like, oh, everything's fine. Meanwhile, your house burned down behind you, right? Because you don't want to be like, oh, I'm at the bank, let me tell you everything that's wrong with my life. So instead, asking people, are you okay? And they started a day in Australia called the Are You Okay Day. And they have a day once a year that people start to ask the question to people, are you okay? Because you'd be surprised, most people ask, are you okay, when they're not okay? Like, I personally have broken down when someone's told me that, because it's hit somewhere in your brain that you're like, you know what, I'm not okay. Like, actually, you know what, I'm not. And then people open up a lot more. So I think asking more of those open-ended questions rather than the way we've been trained to interact with each other can make a big difference.
Absolutely. I want to work back this way, Jason, because on that point, I have friends all the time that ask me, hey, Joe, are you happy? And I'm often struck by the fact of how rarely that question is ever asked. And so I think obviously we're talking about adults and also children. They're a little different, but maybe talk to you, we talk about kind of mental health CPR and first aid. What are those type of things that you think from your experience are some of the best and easily mastered skill sets?
Ooh, easily mastered. I think that's a big ask, but I think some of the things. So I find it fascinating that human beings aren't really born with blueprints of how we operate. I mean, psychology and sociology. We have entire studies in college to understand us because we don't have that internal awareness, right? And so that's why it's so important for society to get educated on what's healthy and what's not healthy. I think the biggest skill that I think I would love all kids to learn is going through your emotions is healthy, and going around them gets you in trouble. Most human suffering comes from avoiding your emotions or trying to go around them. And we love to try and get positive change without going through pain, right? But mental health and physical health, like working out, are very similar. If somebody said to me, I want to get fit and run a marathon or bulk up or whatever, but I don't want to sweat, I think we would all go, well, that's not going to go too far. So when it comes to mental health, I think one problem that we're having is that we often teach kids, like a kid gets upset and then everybody freaks out and is like, okay, send them to the nurse. It's okay, are you okay? And they teach them that their negative emotions are dangerous, right? And now we're pathologizing a perfectly healthy human state that we have. And we all know if somebody's grieving or going through a breakup, we don't say they're depressed, right? We say they're going through a normal mood state, we get that. And so I think a major thing for society, a skill set to have, is recognizing that our negative emotions are good emotions, there are no bad emotions. Every emotion we have has a purpose. And going through your emotions, one, is the healthy thing to do. That's how you process and get to the other side. The more you avoid your emotions, the bigger and less manageable they become. And that's oftentimes when people are having mental health problems. It's because they've been avoiding for so long that they become so big that walking through them alone has become nearly impossible. So if we're walking through it the whole time, we get that better control and that better management going. I think the other piece of it, besides facing your emotions and not pathologizing negative emotions, I'll have teens come in and say, I'm so depressed. And I say, well, are you depressed or are you having a bad week? And they're like, oh, I guess I'm having a bad week, right? Using the right words. The words that we use are important. When we say this caused PTSD when it was just a bad dinner date, right? That's using the wrong language, right? And then our mind interprets that because our mind listens to what we're saying. So not over pathologizing things, I think, is a big thing, and normalizing. I feel like I'm ranting, but anyway, in the book, we call it a major depressive disorder. Why do we call it a major depressive disorder? Because minor depression is normal, right? They threw a major on it because being mildly depressed is normal. And then the last thing that I would say is being kinder to ourselves. we all have an inner critic that is constantly putting us down, constantly telling us that we're not good enough, pointing out our mistakes, and our inner critic is not bad. Too much inner critic is bad. And so I think if we accept the fact that we don't want to eradicate this person inside of us, have more acceptance around them rather than see the inner critic as something pathological, but also being able to counter with more positive self-talk is another great skill to help with mental health.
Absolutely. Audrey, I want to come to you. I think to Jason's point, you have a lot of people that get kind of desensitized to issues, right? I think that we all can be guilty of finding ourselves in situations, certainly I know I am, where you're in a rush to go to work and you're walking down the street and there's a homeless person, and somewhere in the back of your mind you're wondering, is that person alive or are they dead? I hope they're alive, and you continue because you're going to be late for a meeting. And I think that sometimes we can have that same type of approach when it comes to mental health. And so I think from your experiences on your day-to-day, what are some of the issues that people have accessing care in Westchester? Because I think sometimes it's easy to feel as if, oh, this is normal, when we have to convince people and remind them that your difficulty accessing government services that your tax dollars pay for, that is abnormal, and you should not be accepting it blindly.
Right. That is a big issue for our constituents whom we talk with at NAMI Westchester, is accessing mental health professionals, finding a good psychiatrist or therapist that the person can relate to. And one of the things we do is simply acknowledge that it's hard. Having a mental health condition and seeking help is a hard thing to do, and we're here to help you get through it, to cope with it. As I mentioned, you can call us and we will direct you to resources that you may not have considered when seeking mental health treatment. We also, to Drew's point about the youth, we have a program that's called Ending the Silence, and we bring two volunteers to talk with middle school students and high school students, as well as church youth groups, synagogue youth groups, and talk to them about what are the warning signs of mental illness and what do you need to do about it? How do you get help? And we've found it, especially since COVID, to be very, very popular. We also do our program since COVID. We learned how to do it on Zoom, and that's very nice and very convenient. You don't have to put your shoes on and go out of the house. You can just sit, and we're able to be effective that way as well on the Zoom. But we're here to support you, any issues that you have. Dealing with mental illness, dealing with your feelings about it, please come to us. We can give you a hand.
Absolutely. I think to that point, Michael, I want to come to you. I don't want to put you on the hot seat, right? But how do people make the county's job more difficult and then perhaps your job easier to apply more pressure using the leverage of the bully pulpit that the public does have to make sure that a lot of these deficiencies that we're talking about can actually get addressed? In your experience, what have been the most effective levers? What hasn't worked? And then I think also moving forward, what are things you think people could be doing in the future?
Yeah, no, that's a really good question. And I've been in county government for 30 years, so it's been a long time. And I always remind people, just like physical health, mental health is funded, 90% of the funding is insurance or out of your pockets, right? So our department gets roughly about $70 million a year from the state or federal government, but that's to fund things like housing, or we now have a mobile crisis team where we have mental health staff embedded within the police department or in school. But a majority of the services we're talking about are insurance driven. So in terms of advocacy, it's really elected officials putting pressure if you work for an employer to make sure that your benefit package is in parity with physical health, and it's who we elect in Congress, it's who we elect in the state to make mental health a priority. So that's probably the biggest voice we can have. I also just wanted to touch briefly, because we haven't talked too much about racial, cultural, and linguistic competence as it relates to mental health. And I've had the pleasure, last week we did a report for Asian American Pacific Islanders in Westchester, the second growing population in Westchester. And I've also been meeting with the African American men of Westchester. We had a meeting last week with the Latino Coalition. And we also have to look at what some of the barriers or strengths are in a very diverse county. And I read a study, out of 20,000 people that are part of looking at evidence-based practices, which I totally support, only 4% were individuals were African American, 2% were Latino, and 0% were Asian American. So it's not that these evidence practices aren't effective, it's how we deliver, how we connect with various diverse communities on the messaging and making sure they're racially, culturally, linguistically competent. So when Dr. Drew talked about Soul Shop, we've been spending the last 2 years meeting with faith-based leaders to incorporate within the sermon, within their teachings, mental health, because that's where many communities of culture, different cultures, go for healing, go for support. So we're trying to train those faith-based leaders to be the voice or the opening of the door for mental health. The Asian American group that we met with, they made it very clear that they're not going to disclose mental health as an adult because that puts shame on their family, that they're less than. So we have to find ways of engaging, having conversations, I think as Dr. Jason said, to really break some of those barriers so they truly can benefit from those evidence-based practices. But we have a long way to go in terms of achieving those goals.
Absolutely. Michael, I want to talk to you because or Dr. Drew rather, because you sit here and you talk about obviously the limitations of government, right? That at the end of the day, aside from our best efforts, resources are limited. Certainly in the private sector, certainly in the innovative space, we do see people trying to find techniques and new practices that can help lower the cost of delivering the kind of care that's going to enable people to have access to the services they need. What are some of those? I know I've worked with some institutions. They've had mentorship, which has proven to be, in some cases, an effective kind of intermediary step, finding somebody with similar life experiences that you can share some of the things you're going through. But from your experience, what are some of the things that you think?
Yes, I want to jump off the back of something that Michael said, which is, and build on that too. One of the things that we've seen in the system of care broadly, whether it's health, mental health, substance use, is there's a race to push down costs. And that's a little bit problematic. To be frank, that's one of the reasons that we're in this current crisis right now, because people aren't entering the field. People aren't entering the field because if you get a master's in mental health counseling or a master's in social work or a PhD, right, you're starting with a master's at maybe $60,000 a year. Compare that to someone who gets a master's in business, an MBA. They're starting at $120,000, $130,000, $150,000 a year. And so there's a real kind of push downwards to decrease the amount of money that healthcare costs broadly. Even primary care physicians, psychiatrists, all of them are in great shortage. So we have mental health providers that are in great shortage. We have primary health care providers who are in great shortage. And it's a little bit about pushing down costs. The problem is that the pushing down costs hits the people who are delivering the services. And we have a fundamental problem, as I think Michael acknowledged, which is insurance companies, they're companies, they're businesses. They are looking to earn a profit. They have to deliver profits.
Are named after them.
Right. They're literally looking to deliver profits to their shareholders. They are not looking to spend money on costs. So they also are looking to decrease costs. And the net effect is people don't enter the field of care. And so that's a big problem. We need to, as Michael said, focus on parity. focus on the fact that services are being delivered at an exponentially lower cost than they might be delivered by a physical health provider. So that's one piece. The other piece is to really focus on peer support specialists. And people with lived experience in order to deliver supports to people. And I kind of want to refer to them as almost as paraprofessional services because they help complement the work that's done in psychotherapy, right? Dr. Joe or Dr. Jason was talking earlier about like, help me to make friends, help people to make friends. And so that's some of the work that peer support specialists can do, certified recovery peer specialists. And there is also programming, to be frank, that's happening through funding from the state presently. So an initiative that's just getting launched now is focused on helping high school students to access pro-social, non-substance using activities in the community to build peer supports, but to also build interest. One of the things that happens as we develop mental health or substance use concerns is our interests narrow and become progressively more narrow over time. And so do our social circles as a consequence of anxiety or depression basically driving us towards increased isolation. And so it's important for these kinds of programs, prevention-oriented programs, to also supplement the work that's been done in therapy by professionals like Jason and others.
Absolutely. I know we could keep going for a little bit here, but did want to pause to see if there were any questions from the audience. Certainly we have a talented panel here with a wealth of knowledge. I'll start with this young man here and then you can go ahead.
My question is for the commissioner. How is it going as far as, well, because you're in the county, so I can't say for the state, but on the county level, what are the changes or what are the conversations that are happening between people in the community and mental health and the criminal, in the criminal justice system? I've been, I don't want to say a victim of, but I've had a brother deal with mental health issues that never received the things that he needed and ended up going to state prison for 4 years that extremely deteriorated him even more, whereas he was not evaluated and, he went there because of a mental health breakdown and it was treated as a regular incident. Even in the reports itself is very clear. He spoke in his reports, he was hearing things in his head, he was running from himself and things of that nature. So what are how's that conversation going?
Yeah, that's such a great question, and we can spend like 2 hours on that. And I always use the analogy, when there's a fire, who do you call? The fire department, right? When there's a safety issue, who do you call? Police. When there's a medical issue, who do you call? Emergency EMS, right? When there's a psychiatric crisis, who do you call? Silence, right? Because none of our systems are really set up for 24/7 quick response. One of the things that we've done in Westchester, and this isn't the state, this is Westchester, we spent over $8 million this past year, where what we do is we do 911 diversion training, where every dispatcher in Westchester County has been trained, whether it's Yonkers or Greenberg or Peekskill. When they get that 911 call, we have an evidence-based tool to assess the person's mental health status. Is it suicidality? Is it hallucination? What is it? And then we have a 24-hour where they can link to a mental health crisis line that will work with the dispatcher and the individual. We also, every police officer is required now to go to 40 hours for a full week of mental health training in the academy. That's beyond the hours that most counties have done. So my team, along with police, we train new recruits who are in the academy and also some seasoned people because they got to come back and refresh on how to de-escalate, how to handle a person who may be having an hallucination or someone even on the autism spectrum where there's more of a sensory issue. There's some police officers who obviously do it better than others, but the training is there. And finally, more recently, we funded 8 mobile crisis prevention teams to actually sit with the police department. So Yonkers has a team now, roughly about 12, 14 staff who are peer specialists, certified alcoholism counselors, and clinicians who are actually sitting with the Yonkers police or sitting with the Peekskill police, as WJCS is that team. When they get a call, right away they say, should it just be a mental health response? Do they have to go out together, or do they have to secure safety with the mental health team kind of right behind the scene? So we started this about 6-7 months ago, and we're proud of it, but we still have a long way to go. And it's sad because when you look, I spent a lot of time in our county corrections. Many of the individuals have a co-occurring issue, mental health substance use, a mental health issue, and they really shouldn't be in jail. We're also fortunate now to have a district attorney who is doing a lot of diversion programs. So if a person has a possession first time, or maybe has done a misdemeanor crime, rather than setting foot into court to even have a record, we have now diversion programs where they'll send the person to us, if the person agrees, to go to like a 3 hours of mediation and reflection and sort of looking at what the needs are that led to maybe that poor decision before they enter the court. Because once we enter the criminal justice system, which is disproportionate, I don't think we have to say that, it leads to other pitfalls and lack of opportunities. So we just need to advocate for more of this. It's cost effective, it's better for our residents. And again, this is something the county's funding. It's not state funded, it's not federal dollars, but we need to promote more of this in our communities. I hope I answered your question. Okay.
Yeah, just to build on that, Dr. Drew, I want to come to you because certainly, obviously, when you look at county governments, local governments, cities, municipalities, right, we become, in many ways, the case study for what can and should happen on a broader level. As we deal with the evolving and changing nature of work, right, knowing that we have artificial intelligence that is coming, as we know that increasingly certain jobs are being phased out. Also, the nature of some existing jobs is changing. The nature of being an executive assistant back in the 1960s or the 1970s is very different than being an executive assistant today. How does that relate to what are the requirements for being a corrections officer, for being a police officer, for being a dispatcher? How do we find the ways through the work that you're doing to bridge that divide between providing services today, but also training the next generation to a different standard from the people who are currently on those jobs?
Yeah, I think, to take part of that, a lot of it is looking at creating systems of care, right? And that's something that the county has been very actively involved in, right? So that it's not like one person who's responsible for care or supporting individuals. It's a therapist, it's a psychiatrist, it's a peer support specialist. It's also apps. So there are technologies that can support people. There are a number of different technologies out there that it would be really nice if we could integrate readily and that insurance companies would pay for, because there's technologies where a therapist can be in contact with a client, or a client can reach out to a therapist in a crisis and get immediate support. Technologies like that also help to keep a regular check-in with clients, because sometimes people with mental health or substance use issues don't reach out when they need to reach out. And there's actually technology that's been developed that can actually predict when someone might have a mental health or substance use crisis and then be able to alert teams. But part of the problem is that insurance companies don't pay for it. So it's hard to actually get any of that implemented. And a lot of the wonderful stuff that's happening in Westchester is incredibly innovative in terms of 911 diversion. We are also fortunate to have, answering the gentleman's question from earlier, we're fortunate to have two On Track New York programs in Westchester that focus on reaching out to people with early episode psychosis or first episode psychosis to engage them in care and support them in whatever their journey is. And we also are fortunate because we have a ton of other programs that the county is really pushing out, including including through a more recent opioid settlement funds, different levels of prevention treatment, integrated care. So there's a lot of resources out there for system change and development. But really, a lot of this change is about people. It's about making sure that the person that is in your life is able to support you, but also making sure that there's a person that you can engage with when you do have problems. We've seen artificial intelligence and its promise. We've also seen from some recent research that artificial intelligence does a really good job of emotionally supporting people, right? It does a lot of the responses like, it sounds like you're really having a hard time. It sounds like this is happening. But it can't necessarily at this point help to have people change. And so it really does boil down to person power and supporting person power over the long term.
I know I saw some other hands out there. Yes.
So I don't think anybody wants to talk to a robot, but I think they want to talk to a person.
Yeah.
When you call the suicide hotline, nobody picks up. So you're sitting there and you're ready to kill yourself. You just want to talk to somebody. What's your thoughts? I don't want to get online and talk to a robot if I'm feeling like I want to jump off the bridge.
Yeah,
100%. I don't know that there's a new 988 number. It's the federal government went to, because the regular line was very difficult to remember. So as of June of last year, the entire country went to 988. So what we did in Westchester, if you had called 988 or the previous number, you would have got a really nice person or machine in Syracuse, but didn't know Westchester. So if you call 988 now, you should get a live person 24/7 who's actually sitting at St. Vincent's in Harrison. If you don't get a live person, let me know, because we're giving them a good lot of money, and I'll give you my card, because you're absolutely right. If someone's in distress, someone's in crisis, they need a live person. And since last year, I think they've gotten, I want to make sure I got the numbers right, 2,300 calls in Westchester, and the majority of them, they were not people who were actively suicidal. They wanted to connect with someone, they wanted to speak to someone, they wanted maybe to talk about their stress, anxiety, and acknowledge it, and then maybe refer them to a service. So if anyone in Westchester with a 914 calls 988 and doesn't get a live voice, please let me know, and I'll give out my card.
Thank you.
Audrey, just wanted to get you in on this piece here, just because I often wonder across government, not just here in Westchester, but also at the state level, at the national level, that so often you hear sentiments like that echoed, right? Where, I've traveled in New York State and listened to people say, I call my congressman's office and no one answers the phone, right? I call my senator's office and it's just, loneliness, right? With your organization, or just with any of the organizations that you work with, do you have the opportunity to do some stress testing, so to speak, with these organizations that we are providing a great deal of access and resources to ensure that people are getting the services we're paying for?
Well, NAMI Westchester, NAMI New York State, and NAMI National all have helplines. NAMI Westchester's is Monday through Friday, 9 to 3. The other ones are more comprehensive. But when you call those lines, we're not trained therapists, but we can help you get to one, we can help you get to the resources, and also just talk it out, so to speak. That's what we're able to do.
I think you're kind of minimizing the role of NAMI. NAMI, because they're sort of neutral, they don't represent the county, they don't represent WJCS, they hear from each other. If someone's not getting a response, if an agency is not saying what they promote, or the government's saying, they're not doing. So I think you probably hear a lot of the real talk on the street from people who've tried to access the many services. So I meet with NAMI regularly, and they kind of say, this is what we're hearing, this is what's not working. They hold us accountable. So I think encourage people to call NAMI as well if they're experiencing some challenges, because they are neutral, they're not a funding source, and they let the appropriate, whether it's an elected official or government or agency, know.
And if I could just add, I would love to add. The other thing, I think NAMI accepts volunteers,
absolutely.
right? And so, connecting to a person is a valuable thing. When prior to going to grad school, I was a crisis hotline counselor as a volunteer. And it was hard work, but it was incredibly valuable work. And that's not something that you need to be a professional to do. And so a lot of things like NAMI's Warm Line offers support and compassionate care at times when a person's having a hard time accessing care. So I really encourage people to volunteer and support because it's the community that makes the difference. It's voting too, but the community makes a difference. So if everyone in this room, for instance, not to put pressure on you, were to decide tomorrow to volunteer, that would make a world of difference in terms of people being able to find support.
Absolutely. Jason, I want to bring you back into this conversation, but...
Could I comment?
Yeah, sure, go
on
ahead.
That?
Yeah.
Yes, thank you, Drew, for saying that. I myself am a volunteer. I volunteer as president of the board, and I've been a family-to-family teacher for over 10 years. I've done a number of the programs that I mentioned. We very much welcome volunteers, and we do train you. We don't just stick you on a helpline or to run a support group. You get good training. And I also wanted to echo what Michael said. We get calls, we get information from our volunteers, from our family-to-family and support groups about issues that do come up in the county, and we do call Michael, and we do tattle on agencies. So, feel free to let us know.
Yeah, certainly. Jason, I want to bring you in here because I think so many times you'll talk to individuals and, once they finally get to somebody like you, they say, well, thank goodness I found you, or where did I find you? So could you maybe talk a little bit about some of your experiences, the pain points that people have experienced on their way to finding somebody like you who can give that in-depth cognitive behavioral kind of experience?
Yeah, you'll be surprised how many people I get on the phone with that says I reached out to 50 different therapists and you're the first phone call that I had, because the system is inundated. There's way more need than the amount of providers that we have, and so it's a serious problem. And then on top of it, I think you keep hearing us say the word empirically supported treatment, so I just want to define that real quickly. So when you go take a medication, if you went to a doctor and they said, here, take a pill, there's no research behind it, I think it's a good idea, go for it. Most people wouldn't take that pill, right? But when it comes to therapy, there's a lot of therapies that don't have research behind it. And there are therapies that do have research behind it, and that's empirically supported treatment, and there's empirically supported protocols for decision trees in order to do things. So I think another piece of it too is not just getting more providers out there to see people, but getting providers that do empirically supported treatment, because the providers won't be overwhelmed if they're getting people out quicker. If you have someone staying in therapy for 2 years rather than 3 to 6 months, right, that just limited that person by 3 quarters, sorry, not just a quarter, right? It's a major difference. So I think on the spending level, it's not just getting more money for mental health, it's how are we spending that money? Are we spending it on effective treatment so people are actually getting better, to open up spaces, so it's not just getting more providers out there, but getting providers that get more people out through the door?
Absolutely. I think we're running low on time. I wanted to get a few questions. Yes, ma'am.
I think you have your hand before me. I had a
Yes.
comment. So, Michael, I believe your name, you said that, I don't know, Drew?
Oh, Drew.
You said that there was a spending down with regard to salaries of mental health professionals.
Yeah.
But I think on some level, or many people have theorized, that just like teachers, mental health providers are identified with the populations you serve, which in society perceives you as similar, as parallel to the population that you're serving. So you're serving people who are poor, who are marginalized, who are disenfranchised,
Yep.
and often Black or Latino. And so they look at the providers with the same levels.
Yep.
So in terms of advocacy with regard to teachers, educators,
Yep.
Congressman Bowman has put through legislation to give a base salary for educators.
Yep.
With regard to your advocacy, have you done the same to advocate that people who are coming out of graduate school with masters have a base salary, just like teachers, of $60,000 in New York State?
Yeah, and $60,000, to be frank, wouldn't get us to where we need to go.
You're completely right,
Yeah,
but
yeah.
at least
Yeah.
there's an awareness that there needs to be some type of advocacy for salaries to bring people up into the profession.
Yeah, so organizations like WJCS, people like myself, organizations like NAMI, Commissioner Orth, are constantly advocating for healthcare parity, for better rates, so that we can increase base salaries, so that we can attract people to the field. One of the problems is ultimately, if you have Medicaid, sure, you're able to access services, and maybe in some ways you have better access than some, but not always. And then if you have commercial insurance, you have a real challenge accessing services because they're among the lowest payers in the system. And if you're able to pay out of pocket, you're fine. You can access services relatively easily. You still have a challenge. I just lost that.
Oh, we're running low on batteries here, but perhaps.
You just brought up an interesting point, because I want to talk about disparities and not to minimize anybody's experience. And I used the example for those of us who were around in the 70s or 80s when there was a war on drugs, right? What was the messaging? Drugs were bad. If you took drugs, you were a bad person. There wasn't any money going into treatment or evidence-based practices. And I don't say this disrespectfully during the opiate epidemic, but now that there are more white people of privilege who have experienced the opiate epidemic, all of a sudden you have high-cost medication-assisted treatment. It's not criminalized as it was in the 70s or 80s. So when you talk about health disparities and your point about mental health, many of our public community-based clinics do serve diverse communities, but often communities of color or disenfranchised people. It's okay that the New York State COLA, cost of living increase, only went up 5%. And no disrespect, because my brother is one of them, who is in private practice. He can charge as much as he wants because people who can pay out of pocket, which aren't many of us, can afford it and they can get access to it. So that COLA has to be risen. We have to prioritize and we have to recognize health disparities in this country, not only mental health, but also physical health. And was that evident during the pandemic more than ever before?
Yeah, sure. Quickly, because we want to make sure we get.
Two things. I wanted to compliment the lady there from NAMI because you're doing an excellent job finding people to serve on your boards who are institutional in the community. You have people from the Black sororities, Black fraternities, who are invested in their communities. And then the last question I had was with regard to beds. So is Westchester County still doing the 72-hour assessments when they pick people up off the street? Are they utilizing? Because when we're watching bail reform, which everybody's talking about, most of these people who are through this revolving door of violence are mentally ill. What is the status of the 72-hour assessments? Are they keeping them once they realize that they're mentally ill? Are they letting them back out on the street?
Let me answer that. Yeah, it's a big issue, and our emergency rooms have become sort of like a default system. I, as commissioner, or police or other entities can order someone to be brought into emergency department to do an assessment. What unfortunately often happens, depending on how they're assessed, what the presentation is, and whether they meet medical necessity, unfortunately, because of the shortage of hospital beds, because behavioral health beds are at a shortage. They actually closed psychiatric beds since COVID. Some of it was legitimately because of the need for the medical, but a lot of these hospitals haven't brought the beds back up to speed as they should be. So as you mentioned, it's a revolving door. Yes, they can keep people. one of the biggest criticisms I heard this afternoon when I met with many of the police departments was they pick people up, they don't want to arrest them, they bring them to the emergency room, literally 5-6 hours later they're back in the street, nothing was done. If anything, they were more traumatized than before. So the governor in her recent budget she's going to penalize psychiatric hospitals for not opening psychiatric beds that should be open. But again, we have to make sure that happens and that there's advocacy.
Yes, ma'am.
Hi, so my name is Angela. I am a psychotherapist in Yonkers. So I wanted to let you know that. So I have a couple of comments and a question for Commissioner Orr. So my comments basically, I really appreciate, whoever put the forum together, the people, because it's very, very important. My concern is that the panel does not represent the people in the community that is in great need. And if I walked in here and I was a person of color and saw who the panel was, I say, here we go again. I'm in Yonkers, I need services, and there's no therapist, there's no people in the community to help me. And I came because I think I saw it on Facebook. I said, I'm gonna come and see who's there. So I'm really saddened that the amazing panel does not represent the people in the community who are in the most need. So that's my comment about that. And we all know there is a dearth of clinicians, particularly people of color, because for a lot of reasons, a lot of people of color just don't go into necessarily the mental health field. So my question is for Commissioner Orr. As a county representative, what is the county actually doing to recruit more clinicians of color to be not only in public sector, but also in private? Because even though, I'm a newer Yonkers resident since 2014, I lived in Manhattan for a while, but I worked for Yonkers General St. John's Riverside for many years, right out of grad school. And not much has changed in terms of mental health services from my vantage point in Yonkers.
Yeah, first, please call me Michael, and secondly, I acknowledge and totally agree with your comment. And I always feel, that's why I love coming to communities, because I learn more from communities than I share with them. And I can't speak for the Yonkers community, I can't speak for the local service delivery. We fund a lot, we meet a lot. I work with the police and I work with Superintendent Quesada and Deputy Superintendent Rodriguez a lot, and they're good partners, but I don't reflect and represent the community. So I totally acknowledge that, and I think some of us can speak to that on our own. Recruitment has been a big issue. I meet monthly with the 13 colleges in Westchester, and I look at what their enrollment is in social work and in human services and psychology, and I think we're all struggling with that issue. We met with a big ally of mental health, Assemblywoman Shimsky, who recently became part of the Assembly. We just met with her before I came here, talking about how can we build incentives, whether it's financial, whether it's career path, especially for therapists of color. We have a long ways to go. I think, as someone mentioned here before, how do we even start working with high schools to inspire people to be in this profession? Communities doing more work. We have started a project with the African American men of Westchester where we're trying to do a recruitment plan, and part of our meeting with the Latino Coalition last week was how can we get people even interested and then make a living in this work? So to answer the question, I have no answers. We're all working together, and if you have, or anyone in this room has ideas, and a lot of our agencies have hired, because there's such a need for Spanish-speaking, linguistically competent psychiatrists, and Dr. Drew can talk more about this. Maybe we'll have that person for a month or two, and then they're moving on, because there's a lot of opportunities. So how do we build that workforce? So I think we're all in this, and any suggestions, any meetings I can go to, any opportunities, we'd love to talk more about it. I see we have a hand up in the back.
Yes, sure, yeah.
This question is for you, Commissioner.
Michael, please. We're all friends here.
So I am the interpreter, but nobody needed my services today, right? So I speak English and Spanish. My full-time job has taken me to many psychiatric office for years. During the pandemic and thereafter, I've been knocking on their offices and they're closed. I had to switch because psychiatrists are not in their offices, right? We were told that their rent is being subsidized by the government. So they have no incentive in returning to the office. I am a parent of a child with special needs. So I'm curious, like, how much longer is this going to go on when there are so many people that require the services of a psychiatrist?
Is it okay? I'll take a stab, but I want to ask our other panelists. One of the, and I hate to say good outcome, but in primary health, prior to the pandemic, you can use virtual health. It's a billable service because doctors could use it. It never was allowed in behavioral health. You could not do a virtual meeting and bill for services. So the pandemic did bring this new technology to people who would never go to an office, but are very comfortable and willing to use technology or virtual health. So there was a lot of good things that people wouldn't have had access to, but now they do. With that said, and Drew can, and maybe you guys can talk more about, there are a lot of therapists who struggle getting back to the office. They became comfortable with telehealth, and I'm just going to speak from my 5 cents. Many of the agencies were reluctant to make them come back because they also experienced trauma, but they were afraid they were going to lose that therapist if they were going to make them come back to the office. And that's a sad commentary, that they were so afraid to say, hey guys, time to come back. We can offer a mixture of virtual and in person. As a county, we monitor along with the state the programs. By law, if a person in any of our community-based mental health clinics want to see a therapist face-to-face, the agency has to respect that. They can't say, no, I'd rather see you virtually. So legally, regulatory-wise, if I walked into a public health clinic and I said, I don't want virtual, I want face-to-face, they, by regulations, have to see you face-to-face.
So in many clinics, they do have the face-to-face, but the provider is working from home. They actually have the patient sit in front of a monitor and they can see, and that's called face-to-face.
Not in terms of regulations.
Exactly.
Yeah. So it doesn't count for face-to-face in terms of like the regulations, but I think one of the challenges, we've been talking about the workforce and how the workforce just isn't there, and how we really need to get people to engage in financially accessible services, right? The services at this point are not financially accessible, and are heavily limited. So one of the things that organizations really have struggled with, particularly for psychiatric services, is psychiatrists can essentially go wherever they want and get paid for their services, and do telehealth. And so it becomes a little bit of a challenge to then say, listen, you need to be in the office 3 days a week, or we can't employ you because then we won't have a psychiatrist. And so by regulations, we have to have a psychiatrist. And so it's sort of a pickle in a lot of different ways. It's how do you retain staff? How do you attract staff? And the flexibilities of telehealth have allowed us to retain and attract staff. But to your point, right, it shouldn't be the case that there are a lot of people.
I can tell you offices where a nurse is the one running the show, and the doctor is in Florida. Yep. Or I mean, it's like, how do you do that to a patient that requires help, that requires, those injectables for the treatment?
Right.
I offer a patient saying, when I go back to the garbage cans, I know that I need my injection.
Yes.
Well, where are the doctors to do that?
Yeah, so injectables are actually a really interesting situation. So injectables are something that a lot of psychiatrists have kind of stayed away from. And so the only way to really access injectable medications is through a hospital-based program, or frankly, from a community-based program. I can tell you MHA, WJCS, Guidance Center, all of them do injectable medications. But it's usually delivered by an LPN or an RN, not the psychiatrists themselves. They don't do injectables.
But the therapist has to be present and they have to prescribe it.
Yes. 100%. Yeah, so yeah, you're 100% right. We need to kind of get people in person to be seeing people more often.
Controlled substances require
Yep.
the doctor to be there,
Yep.
not the nurse.
Yep, controlled substances, you have to be seen once a year in person. Yeah, but absolutely.
Is that okay?
I had a conversation last week with one of the biggest national telehealth spaces, these new platforms that we're seeing on TV, and I don't want to minimize them. It's offered great help for a lot of people who never would have reached out. But when I looked at their profit margin, when I looked at the salaries of what they were making, boy, it's scary. They want to sell us things, as you're saying. We know people need to come to the office, get injectables. Many of our young people do need to have face-to-face, and a lot of these platforms are approaching school districts. They're approaching employee assistance programs and saying, we could sell you this service, this platform for all your people you serve. And when I checked how much they were making and what they were in terms of their business, I think some ways they're taking advantage of a very vulnerable time in our society. And again, there's definitely a place for virtual telehealth. I don't want to minimize that, but I would be cautious about that.
Well, I think I want to be respectful of our panelists' time, and certainly as they're filing out here, I'm sure people can feel free to ask some questions. Just a brief summary, because I think it's important. Some of the things that we were talking about here, again, the need for more inclusion from the panel, which I think in some ways is related to some of the things that Nicole has talked about. I know for a fact all of the black social workers I know from Yonkers that I grew up with have left Yonkers because they have college debt to pay off and they don't want to be doing it until they're 80. And so I think that goes back to what is the level of pay and compensation that people are receiving for those services, and how do you keep a community whole if the people who are reared by that community feel as if they have to step over that community in order to achieve their dreams. So I think that is a critical point for us to all take with us as we leave here. Again, focusing on how do we get more people to feel less as if they don't have the freedom to talk about their own mental health issues. How do we get more people to recognize that there are disparities in care? Everyone is not being granted the same level of access. These are key things that I think all of us can and should be thinking about, working on, and I think as all the panelists have stressed, all across this panel, from the private sector to government, to those people who do the work in between the private sector and government, there are resources at our disposal. We need to leverage them. We need to do what we can to make people in our community more aware of their existence. I think that becomes the groundwork, the foundation for us trying to get the more equitable mental health outcomes that you all deserve. So thank you so much for coming. I want to thank Patrick Murphy for providing the services here for the filming of this so that we can share it with other people who were not able to attend. I obviously want to thank Christine Peters for putting this together. And all of you for taking your time out on a Thursday on this lovely day to make sure that we could have some pizza, have a conversation, and make Yonkers a better place. So thank you so much. Oh, and Christine's got one more thing to say.
Sorry, also just wanted to thank the Yonkers Ledger for sponsoring the event. And the Yonkers Public Library for allowing us to have it here. And all the panelists, thank you again for coming up all the way from wherever you came from to Jason, I know, came from New York City. Sue came from New York City. So thank you to everybody as well. Thank you. Have a good night.
Another day in Yonkers. What is funny, I was joking before you came in. I was like, if it's not this, it's like, I'm not going to get back to Yonkers because I'm here. Right?